very good afternoon to everyone. Welcome to our webinar on building the case for surgical robotics in Asia's hospitals. I'm Cindy from Hospital Management Asia, and I'll be your MC this afternoon. Today, we have invited a panel of healthcare leaders across Asia to discuss the growing trend of robotic surgery in the region and the key considerations behind building a robotic surgery program. This is because successful adoption goes beyond simply purchasing a system. It starts from selecting the right system that fits your hospital's needs, to creating safety protocols and training structures, and finally, building a long-term strategy for sustaining the program. So over the next 1.5 hours, our speakers will share insights into how they have built their robotic surgery programs so far. We will have a 20-minute Q&A session at the end, so feel free to type in your questions in the Q&A box located at the bottom of your screen anytime during the webinar, and we will get to them once we can. All right, without any further ado, I'm pleased to introduce our first speaker, Ms. Tran Le Quen, Chief Financial Officer, FV Hospital, Vietnam. Ms. Tran, please.
Hi, good afternoon, everyone. Thank you, Cindy, for introduction. Let me share my presentation. I'm Queen Tran, CFO of FV Hospital from Vietnam. Today, my pleasure to speak with you about our process of adopting robotic surgery. Specifically is for the Da Vinci Xi robot. And the process of how we evaluate the robot as our strategic fit for our hospital, and understand each adoption of the robot different. So this is like a case study of our own hospital, and hopefully by sharing that, we could engage in some meaningful discussion with your situation or further understanding about our process. So because this is about strategic decision of FV, so let me introduce some information about FV Hospital and strategically to see how it fits to our hospital program. FV Hospital is a first international hospital with 100% foreign invested capital in the south of Vietnam. We officially opened in 2003. So it's been 23 years of operation. We have evolved into a full service, one-stop provider of quality care for the local population in Ho Chi Minh City and other provinces. We also serve the expat community in Vietnam, and we also have some medical tourism patients. Currently, we have 1,300 plus staff, among which are 130 plus full-time Vietnamese, and we are doctor, and we also have part-time doctors and external doctor programs. I will introduce more later, but our doctors are Vietnamese, 85%, and then 15% are expat. We provide care for across 37 medical specialties. So we are a general hospital with 220 beds and placed in District 7 of Ho Chi Minh City. So that area is called Saigon South. So in our population of our patients, 75% are Vietnamese and 25% are Westerner and Asian expat. We also have patients for Cambodia and Laos. Right now, the number of cross-border patients accounts for about 8% of our patients. In 2025, the number of outpatient visits is 250,000, and the average of 5% conversion rate into inpatient admission, including surgery, medical, maternity, and other cares. We had the first JCI accreditation in March 2016, and we were the first accreditation in Vietnam. FV Hospital, we have passed 3 consecutive re-accreditations right now. And we're known for the international standard of care, and we commit to clinical quality and patient-centric service. We are very patient-centered program. So this is just a brief highlight. I will not go deeply into this, but part of our strategic choice of robotic means we have to understand our patient very well, where they're coming from, their locations where they're coming from, and they also their income. In terms of specialties, this is some selected specialties. So you can see that we have a widespread of both surgical and medical specialties. Our highlights are oncology, cardiology, ophthalmology, orthopedics, pediatrics, and other specialty cares. We also have subspecialty cares, especially internal medicine area. So compared to other international or private hospital in the area, we actually have a full spread, a more wider scope of services. So in FV, the quality care is our utmost importance. As we said, we have accreditation for 4 consecutive JCI cycles already. We have a strong team to always make clinical quality improvement. We focus on patient safety, and we have testing criteria. Our goals are giving international patient safety goals and access to care and continued care of care to everyone. So we in healthcare, so these are the standard of JCI. In terms of accreditation, besides JCI, our lab also have ISO lab and WestGuard certified lab for how to say market perception. We have high net promoter score. We do a quarterly survey of our patients about their happiness, their satisfaction score, and then every 2 or 3 years we do a wide survey on the market about how hospital service are positioned in Ho Chi Minh City. We have regular quality and outcome programs, and we have for the quality care, we have criteria, and we hit about 100% of our compliance on our internal assessment of our quality. So in our hospital, the strategy is always about hiring and retaining quality doctors. The hospital was founded by the French doctors and headed mostly by the French doctors. But now, after 23 years, we built quite a strong local talent pool. We have altogether about 230 doctors, but out of that, 130 doctors are full-time, so employed full-time by us, and 85% of that are local. But when we hire the Vietnamese talent, we choose the doctor very selectively. They have a well-trained education and experience. Also, we want to give them to introduce a diversified expertise. So we have a commission called Professional Oversight Committee, and that committee choose and select doctor very strategically to develop the hospital. We also make sure that the hospital, when we engage new clinical doctors, we want them to understand what is to work in the private hospital and to build a professional dream for the doctor and the hospital. And the doctors also ambitious to be engaged in modern facilities or new technical procedures that we're willing to develop in FB. So we and the doctors are pretty much partnership. We practice evidence-based medicine. Our philosophy is patient-centric. We are professionals and we uphold ethical standard and quality of care. So our doctors are very happy to work with us, and more than 80%, 60% of our doctors has been with us for more than 5 years, so before COVID, and 85%, 98% of doctor retention rate. So besides the full-time doctors and part-time doctors who work with us through let me go up, who work with us through employment contract. We also partnership with the medical communities. So we have a program called partnership program. Yeah, doctor partnership program. So we have contract with more than 3,500 doctors and medical facilities to refer patients to us. We have contract with more than 400 doctors. We call them external doctors. They are surgeons or obstetric doctors or other doctors working in either public hospital or other private hospital, but they have their own patients, and the patient wish to have procedures done in FV. Then we contract with them, we credential them, so that and they're familiar with our process, so they can bring their patients to FV anytime. We also sign contract with other clinics and facilitator to coordinate the care for patients. We also have consultation slot at FV for usually we choose the expert doctor. We call them associate doctors. So we select doctors that are expert in their skill, and we give them consultation slot in our consultation room. So the whole network of partner reward program, we have a system. We use Salesforce to track them, to track the activities. We have like a loyalty score. So for the activities we partnership with them, we have the partner reward program, and we introduce the WhatsApp Doc magazine to our doctors community every month. Besides that, I'm not listing here, but we also do regular CME program. So at least once a month or a few a quarter, we do CME program in big conference room where we invite the leaders, medical leaders in that topic, or sometimes even like doctors from external like Singapore or Japan or Europe to come and share with us. And our doctors also speak a lot about what we do in FV to create a medical topic to talk about, or new techniques, or introduce what's new. And we issue CME certificate for the participating doctors. So I want to share with you our strategy to develop Center of Excellence. All this program has been done over the external doctors. The doctor partnership program has been working with us for more than 10 years. We've been doing that for more than 10 years. And the Center of Excellence, we started introducing that from 2017. So almost 10 years already. And so far, we built, these are the highlight of our center, and we continue to build more center. But the highlight of our COEs are oncology, orthopedic, cardiology, maternity, and ophthalmology. So the concept of Center of Excellence are the clinical leadership are strong people. They are very experienced and technical skill, and they're willing to embark in a new journey to upgrade the treatment techniques, the skills, and building the team, and building the protocols, the workflow, whatever the training to expand the scope of service in that center, not just in terms of number of procedures, but also by the complexity procedures. So behind all these Center of Excellence are the technology we have to acquire, and then we also build the ancillary, the supporting services like imaging, the anesthesiology and ICU, the A&E, and all the nursing care team. Operationally, we have been working toward, like the how you call it, tertiary care hospital. So we already have that system. We have the MAB called Medical Advisory Board to talk about medical excellence or medical issues every month. So I'm just using the cancer center. We call it Hy vọng. In Vietnamese, it means hope. That's one of our COE. Center of Excellence. This cancer center is a successful story to show you our pathway of development in terms of clinical and financial. Hy Vọng Center is is the most important center of excellence. So we start investing in this center since 2017 in terms of collaboration with SCG. SCG is the biggest oncology hospital network in India. I think they own more than 40 oncology hospital across the world in India. So when we launched this center, the revenue at that time was 2.9 million per year. And after you see 6 years, we launched it at the end of 18. So pretty much 18 was gone. 18 was mostly like the project time. And then after 6 years, our revenue now is 8.6 for this center. So we grow nearly 3 times in 6 years. And it accounts for 12% of hospital revenue. And medical leadership, the head of department is Dr. Basma. She came from France. She joined FV in 2018, early 18, and then she has 25 years of experience. So that was what we've done over the past 10 years. What are we looking ahead for the future? We are building a new building in the hospital land that we have right now. We have some spare land, not spare, being used right now, but we're able to allocate a part of the land to build the third building. We call it H building because we are FEH. So we have the F building, the B building, and now we're building the H building. So this building is designed to deliver world-class specialized care across multiple specialties with state-of-the-art technology and patient-centered environment. So oncology is only one of the specialties we develop, but I'm using this as a one example to see how the robot fits in. So for cancer treatment, basically this building will provide the essential infrastructure to complete our vision, to complete the cancer treatment under one roof. So right now, we are doing about 30 cancer surgical cases per month. But they all scatter in all the surgical departments. But in this new building, we will have a specialized surgical consultation area. So we will select certain doctors, surgeons, we become specialized in oncology surgeries. We will input a PET scan. We have a dedicated oncology ward. We currently have a histopathology lab specialized in oncology testing. But over there, we will have expansion of this lab to take in more genetic testing, the things that we're not doing right now. We will install a cyber-knife system to do oncology treatment. We also do a floor of oncology hematology treatment with bone marrow transplantation. So at this point, at this junction, how do we see the Da Vinci robot fits into our strategic growth? And me as a financial, the CFO, how do I see that as a successful investment and growth for the hospital? So the key question to ask, it's not about money first, but about does the robotic surgery genuinely support our hospital long-term in clinical and organizational strategy? Where we are, what our surgeons, what our doctors looking at, and our international position. So when after you hear my introduction about our hospital journey, we are international hospital from beginning. We are clinical care, and we continuously develop center of excellence. We already have a network of external doctors and also our strong surgeons in-house doing like tumor surgeries, both for oncology and non-oncology cases. So we are ready in terms of where the position of the hospital and also for future the growth to fit into the H building. So it's all fit into one single picture. But before they making a decision about purchase, we need to make decision about the surgeon leaderships. We need to we do of course we have to do some understanding about how to develop the program, and with the training before we develop this program, we did not have any doctors in house who have license or know how to do robotic surgery. So we have to make that plan. So we understand that the strength of the clinical leadership is more important than the robot, than acquiring just a robot. And we have to identify who are the committed surgeon champions and align across more than just one specialties. Okay. Then it comes to evaluation of capital investment, all the feasibility study, financial projection, operating costs, and projected case and revenue and all that. And of course, at this stage, we can only do the analysis in a hypothesis way, right? We know the number of surgeries we will engage robotic surgery in. We know who's the head department and whether they are excited to join with us in robotic program. We know the procedures we currently do in laparoscopy, and how many of that we would estimate to be converted to robot. And we also have to understand the costing of the robotic procedures, and basically estimate what would be the cost per procedures, in a very simple way, to try to estimate what would be a return of investment if we do this investment now. So that process engaged a lot of our patient finance team, the financial people who work directly on building costing, pricing, working with doctors. So they engage a lot in this area to build a realistic feasibility study and try to achieve the vision on implementation. Also, we have to assess what if more system will enter the market. Currently in Vietnam, only 2 private hospitals have 2 SI systems. So Da Vinci, but SI, so it's the previous model. And one private hospital acquired the same system we have, the Da Vinci XI. And we talk in a little bit. They acquired that in May 2025. So we have to look at competitive market in the future, and we kind of keep an eye on the market to see which hospital are keen on develop a robot, and then try to assess different scenario of the model. What if it doesn't grow as what we think? The base case, better case, and optimal case, something like that. Then we have to look at our operations. Are we ready? We have to assess the OR, here we call OT. We in French, we call it OT, operating theater, and OPD workflows. We have to assess the nursing and anesthesia engagement, the credentialing, and then also, Ministry of Health regulations on that to ensure the smooth incorporation of our robotic program. It is, at that time we know, we was told, but then after that we start to experience now the robots actually introduce a new operating model. It's not just an equipment, but yet at least we make the decision with informed information. So the financial assessment have to be long term. So we look at the model of 10 years, and then we try to analyze the utilization of the system. And then we have to expect the ramp up period with the training and with the specialties that we have in mind at the time, and the doctors we have, and we have to also evaluate on the case mix. It's an evolution, because the more the doctors do, the case mix will grow from simple to more complex cases, and the long-term value. So yeah, and also we know that once we have a robot, we're able to attract strong surgeons, famous surgeons, to join us to develop the program. So we look at that perspective as well. And then we also understand the real work we start after the installation. So what about post-installation support, ongoing training, data, and clinical metric record and review and continue engagement between hospital leadership and technology partners means either we work with the distributor in Asia, DTG, and they connect directly with Intuitive, the manufacturer. So we have strong support from them to continue to contribute greatly to the success of the program. So this is our journey of from feasibility to reality. Fortunately, the robot itself, the Da Vinci itself, have proven track record of their success. They have a lot of procedures done in the world and successful case in terms of clinical. I'm talking about clinical outcomes. So for us, the hospital who embrace clinical outcome, of course, that is our choice. We love it. So the robot actually in our wish list for 10 years already, since 2015. We would love to have a robot, but we wasn't ready. And also, it's just like a thing in wish list, and we don't know when we will materialize that. So the strategic decision moment is in July 2025. When I shared with you earlier, is when private hospital in Ho Chi Minh City acquired the Da Vinci Xi in May. They go live somewhere in June. And then by July, we make the decision. We have to, engage in the robotic program to continue being head of the medical market here, like being the top hospital in terms of in private treatment. So then we do the financial and clinical feasibility study from July to September. So it's actually only 3 months. We did all that work, and our board approved the acquisition of the robot in October 25. That means we signed contract. We discuss contract super fast, but we signed contract in early December, and the robot, luckily, DTG, the vendor, managed to have a robot already in Vietnam. So we didn't have to wait for the manufacturing time or importing time, but we're able to have a brand new Da Vinci Xi installed in FV from mid-December. So to get all that done during that period, we had to form a project team with device technologies. We designed a robotic program based on our current clinical strength and specialties and procedures, patient pools. We estimate conversion rates. We do costing, pricing. We decide surgeon fees. We decide consumable. We also have to design, what would be our marketing plan and promotional plan for patients who engage in the treatment early, because we consider this 2026 is critical for the success of the program. So we have to be very, practical about our offer of the robotic program to our patients. So and of course, we have to finalize purchasing agreements with ETG, and then we implement it. So the whole process lasted about 2 months. With the feasibility study, so within 6 months. So I will share a little bit on the lesson that we learned. Just a few points, but the lesson we've learned to develop the robotic program for us is the most important thing is identify the robotic specialties and the procedures and other things with the current resource that we have. Of course, when we develop the program, we have to look for other opportunities to bring in the champion, the robotic champion. And luckily we did, because as I shared with you, none of our full-time doctors were trained in robotic surgery yet. So we managed to bring in a champion from another hospital. And I would say that was a very, very strategic move for us. And this doctor, just a perfect fit to our strategic developing a new program. As I shared with you earlier, what are our criteria to choose ahead of a new program, and he's more than enough for us to build a robotics center. So he already trained in the Da Vinci SI, so he only need like some short time of just a few weeks to practice on the XI, and then he could perform surgery on XI. So having the champion early engaged in the robot surgery give tremendous heads up for the nursing team and other doctors to be excited and to learn about the new program. So for us as the whole clinical team and also leadership, it took us quite a while to understand the structure of the training program of Da Vinci and their intention behind the program. Because they at first we were like, oh, why is it so strict? Why is it only limited to this number of people? Why they need to develop this number of cases before they can move on and train other people? But then after that we understand it is designed in such a way that help the hospital to be successful, and the doctors to be successful in the program. So after we understand the concept, then we just work together. So the Da Vinci robot surgeries covers 5 specialties. And sorry, I'm a finance person, so I mean I'm not a doctor. I don't use much technical terms, but I know it covers key 5 specialties like urology, thoracic surgery, general surgery, gynecology, and ENT. So they do all these hysterectomy, nephrectomy, or colectomy, or all these, like all the surgeries. So over those 5 specialties, we learned that we should impart right away as many specialty as possible. So we end up choosing 4 specialties on the first batch. Sorry, I'm missing the 4 here. Yeah, it's quite critical. So our first batch, we have 4 specialties. We choose thoracic surgery, urology, general surgery, and gynecology. So we have 4 right away. The next batch, we will have 2 more specialties, head and neck, which is part of ENT, and 1 more that not really listed in the Da Vinci program, I think. I'm not sure, but I never see it listed is breast surgery, because we have breast cancer surgery for so long already. So we already have a doctor who willing to do breast cancer surgery on the robot, and we also discover make connection in the French network that we have, because we are a French hospital. Our founder is we have many founders who work hospital doctors, but our CEO who is our key founder also have connection with a French hospital who have breast surgery by the robot. So we are developing that program right now. So for each specialties, we need to strategically choose 1 surgeon at a time. So somewhat there was a competition within the medical department to see who is the first one. So of course we want to open the robotic surgeries to all the doctors in the departments. They all love that. But we have to strategically choose which one. And most of the time it falls into the head department. It's not the criteria to be head department. We choose the strongest surgeon, and it just happened to be our head department. So we choose 1 doctor per specialty. And as I mentioned before, Da Vinci, for us at least, I know, only train 5 surgeons at a time. And then after the training as a certificate, each surgeon needs to demonstrate a learning curve. So there's a minimum number of cases within 3 months that each surgeon have to perform to be called qualified for that, to be independent, qualified, and then a new surgeon can be trained for that specialties. And so that's why we have to roll out slowly, 1 surgeon at a time for each specialties. So because as I said, both surgeons and hospital need to demonstrate success of learning and implementing Da Vinci. So that means we have to track each surgeon performance and medical outcomes. surgical time, recovery time, like that. We need to create patient pipelines from direct and referral channels. We also have to develop patient education material. And then marketing is very important. We need to actively market the actual practice, not just principle, but actual practice. And we talk about clinical outcomes of robotic surgeries and successful cases. So, I mean, this is just educational material from, Da Vinci for us to know, the clinical outcomes of robotic. We have to talk a lot about this because the whole meaning about introducing robotic is about clinical outcomes. So this is my last slide. So I'll just share with you what we see in the last 3.5 months. So this is a number, I closed a number by April 15th, so only half of April. You see that the January and February is in orange because of two factors. In Vietnam, we have the Vietnamese New Year, or the similar to Chinese New Year. So it's like 2 weeks off already. And then our doctors also have a lot of training during this time. So it wasn't a full run of the program yet. So March is a full month with all our doctors are trained and certified. We have 5 doctors. And then April is half a month. But with 3.5 months, we have performed 23 cases already. And you see more on thoracic because we have 2 doctors. The first champion who joined FE is a thoracic doctors. And then we also train our HOD, the thoracic and vascular doctors. So that's why we have a bit more case of thoracic surgeries. I share with you the number of insured and non-insured. So about 40% of our patients are insured and 60 are non-insured. And then we also see some of the robotic patients, the offer of robotic patients, they actually choose to be surgery in laparoscopy. And we have 5 refusals, so our refusal rate is about less than 20%, like 60% or something. So in the result of 3.5 months, we see is encouraging. We are on track, or actually somewhat better. So in terms of number of projection in cases, the average revenue per case, in fact, is much higher than our projection because the complexity we're able to do and the patient willing to pay. Our surgeons love robotic surgeries because it's for both ease of surgeries and patient outcomes. We are opening the next batch of training program for selected external doctors because we work with these external doctors for so long. So next batch will be mostly external doctors, the doctors working in other hospital, but they are strong doctor, they're excellent, they're famous, and they already have a pool of patients. So we open a training program for them, and the medical community are excited. We created a robotic center to design a new area for robotic with consultation room and efficient operational workflow. And we form a robotic surgery steering committee with the clinical heads, with the leadership of the hospital, administration, operations, nursing pool, nursing team. So we form a robotic surgery steering committee to monthly monitor the program. And then we also collaborate with big hospitals in the country and international too. I mean, I didn't put international here to engage in national level of conferences. We are going to do live broadcast conference to more than 1,000 surgeons across Vietnam in May. So that's it for me. Thank you.
Thank you very much for your insights, Ms. Tran. Just getting my video on. Okay, thank you very much. So just a reminder to our audience that if you have any questions, you can submit them via the Q&A tab at the bottom, and we will get to them later. Now, I would like to introduce our second speaker, Dr. Dini Handayani, Chief Medical Officer, Mayapada Healthcare Group, Indonesia. Dr. Dini, please.
Thank you, Cindy, for your kind introductions. So a very good morning, good afternoon, and good evening for all of the participants. I noticed that some of you are located in every place in the world. So let's join this webinar, and I hope you have a good day today. Let me share my screen for the presentations first. So today we're going to discuss about robotic but my type of robotic probably a bit different from Ms. Trans just what Ms. Trans has just presented, because Ms. Trans probably is about Da Vinci, but in my case, we are try to learn something from a smaller scope, which is from the Phallus Robotic for orthopedic surgery. So the title today will be Transforming the Future of Collaborative Orthopedic Practice, how to integrate robotic precisions with the support of ERAS protocol for total knee replacement surgery. So this is part of the Mayapada Orthopedic Board initiatives. So Mayapada is a private hospital group in Indonesia. We consist of 7 hospitals and soon to be 8 hospitals this year. And we also have the initiatives to buy another robotic equipment by the end of this year. Probably with it will be Da Vinci. But this year and also some the last quarter of last year, we tried to learn something from a very smaller scope, which is from the orthopedic surgery and using the J&J robotic, which is Phallus. So this is part of the orthopedic board initiative led by Professor Dr. Dwi Kora Novembri Utomo, MD, PhD. So probably the previous TKR or total knee replacement surgery was reviewed only by the survival of the implant and basic pain relief. And if the patient could survive the basic pain relief and also the implant was survived, then it was categorized as a success. But I think success is no longer defined by implant survival only. So for now, we define success by more specific measurement, which is functional restorations and then patient satisfactions and then faster recovery and then consistent outcomes, which led to success. And there are also some global key drivers, which is the catalyst for change. And all of us, I think, we know that there are pressures on healthcare lately. There are aging populations, which is increasing prevalence of osteoarthritis patients and active elderly patients, because we have healthy elderly in the world with a longer age also. And also, they have the higher functional expectations. So patient demands to be fully returned to sports and also high level physical activities. So not just pain relief, but they want to get back to their life as soon as possible. And also, because of that, they demand for a faster recovery. So there will be a shift towards reduced length of stay and rapid rehabilitation protocols, which needs to be adjusted in some of our cases. And last but not least, because I think insurance is also part of our payers. So we are also moving towards the value-based healthcare approach, which is also we need to reduce the complications, we need to reduce readmissions and overall cost per episodes. So what is the paradigm shift? So this is the traditional model. So the traditional model is focused on procedure driven, and also the orientation is usually the surgeon centric. So it's between the surgeon and the operation or the surgery itself, and also the ward recovery. So actually, the future of total knee replacement is pathway driven and not procedure driven at all. So this is the modern pathway model, which is we need to have a good pathway, or we need to develop our own pathway from the pre-operations and then intra-operations and also post-operations. So the orientation is very patient-centered care models. So it's not a surgeon-centric. And the focus is also pathway driven. It's not procedure difference, but it's like pathway difference. So we have a lot of pathways, and we are going to choose one of the pathways, which is evidence-based internationally. So how to map the modern pathway? So mapping the modern pathway is we need to settle the baseline for the preoperative optimizations. So we need to define what we need to do in terms of preoperative activities. And then second, because we have robotics, so we need to have a precision surgery using the robotics. So how to execute the plan is also part of the modern pathway. And then for the recovery, we are choosing the enhanced recovery after surgery or ERAS protocol, which is reduced variations through evidence-based pathway. And this pathway is also supporting us in a rapid rehabilitations and functional outcome monitoring, which is ensures the long-term success. And this is, I believe, one of the things why we choose the ERAS protocol against or in many options in the world. So there are three pillars of modern TKR, and it has to be reproducible and scalable outcomes. So pillar one, it's about the precision surgery. Pillar two is about the enhanced recovery. And the third pillar is the multidisciplinary team, how the team is coordinated the care across specialties, ensuring the patient journeys is seamless and safe. So deep dive. If Ms. Tran is probably explaining about from the financial aspect, so actually from the clinical aspect, we have also different values from robotic assistance. So what is the value of having the robotic assistance? The first is alignment precisions, because with the support of robotic, we could achieve the planned alignment within below 1 degree or 1 millimeter accuracy. In this, reducing outliers significantly compared to the manual instrumentations. And also, second thing, there's a soft tissue balancing. It could quantify laxity gaps in real time and also allowing predictive balancing before any bone cuts are made. And there are also components for positioning accuracy. So it will optimizes implant placement in 3D space to match patient-specific anatomy and also kinematics. And the last one is the surgical reproducibility. So standardized outcomes by minimizing variability between different surgeons and also different experience level. And I think Ms. Tran already explained about we need to train a lot of physicians and surgeons to be able or to be competent enough to use this robotic. So it has to be standardized because we want to reduce the variations and we don't want every surgeons to have their own different models or own different ways of using this robotic equipment. This is one of the example of alignment precision. So you can see the before and after is very specific to patient's anatomy. So we could see that the precision is very good, and then the patients could really, have their life back, quote unquote. So this is definitely one of the upside of having the robotic surgery or robotic equipment in our hospital. And the second is soft tissue balancing. So before any bone cuts are made, there are manual surgical planning using the robotics, which could make sure that the patient got the soft tissue balancing before and after the surgery, and also measure which tissues soft tissues balancing is adequate for each of the patient type. So this one is very important prior to any surgery in our hospital. So the pillar one is the precision of surgery. So we know that we do have robotics, but again, we have to ensure that robotics is augmentation. So it's not a replacement. So we create how robotics can alter the surgical workflow. So it's not the other way around, but we really use robotic as our augmentations process. So it's not a replacement. So with robotics, I think it helped us in terms of technology. And also we have the upside from patient anatomy, just like the one that I've mentioned earlier. And with this upside or this benefit, we could do the pre-resection planning, which is all plans, cuts are based on the CT or the intraoperating mapping first. And then the step one, there is a real-time feedback. So whenever we have any data prior to the surgery or during the surgery, or usually it's prior and during, so we have the real-time feedback. So what is the gap? This is the thing that I mentioned about the soft tissue. So we could really get the gap tension and alignment before and after. What is the plan and what is the existing situation, which is very beneficial from this robotic equipment. And the third one is we also could control the resection accordingly, because there are haptic boundaries, which is prevent tissue damage. So if something wrong, we could immediately stop the surgery, and it gives us a lot of benefit, because then we could do anything as planned. Because if anything was not done as planned, then the equipment will, stop for itself. So this is the critical caveat, which is technology is a tool. It augments precision, but cannot overcome poor indications or lack of fundamentals clinical knowledge. So it helps the surgeons to get the best technology, and the surgeon has to have a very good understanding of the patient anatomy, and also a good knowledge on how to plan a surgery ahead of, and get the best result with this additional technology support. So this is the actual uh, the actual experience that we have in Mayapada. So it's not the other way around, because some of the physician, they feel like because of the robotic they will be replaced, but we will make sure that this is a very good augmentation, and everyone needs to be competent to use this robot as an augmentations equipment, not as a replacement. And then this is some of the evidence snapshots about robotic surgery. I believe that although some of the result showed a very good data, but they're still unclear in also some evaluations that we need to really review for the large cohorts. Because I believe that many parts of the world already use robots by now, but accumulating all the data and really have a good measurements and evaluations of the large cohort will give us a lot of beneficial data and additional information. What is the real benefit and the real support that we could have for the robotic surgery? And the pillar 2 is about the ERAS protocol. So it calls the enhanced recovery after surgery, or simplified by ERAS. Is a multimodal evidence-based pathway designed to reduce surgical stress and also accelerate recovery across the crucial three phases, which is the three crucial phases, which is the pre-operative, and then intraoperative, and also post-operative. So ERAS is a multidisciplinary team approach. So as you can see in the slide, there's a name of Prof. Dicora, but you can also see in the other slide there's other surgeon names as well, or supporting a physician as well. We will see the names on the other slides. And it's an evidence-based protocols, and it was proof that it was reduce the surgical stress, because from the perioperative to the postoperative, it was very short, and the patient is getting full support. And we will make sure that the early discharge is no compromise to safety. So although we have a very good discharging patient time, but we will ensure that early discharge is without compromising safety. So there are three phases, like I mentioned earlier, the pre-operative, and then intraoperative, and also post-operative. So this is where the multidisciplinary the multidisciplinary team works. So for the pre-operative, it's the charge of Prof. Dicora as an orthopedic surgeon. And then for the intraoperative, it's a joint between Prof. Dicora and also Dr. Agus, which is Dr. Agus is our anesthesia. physicians, and also Dr. Johan. Dr. Johan is, I think, in charge from the pre-operative and also post-operative one for the early mobilizations and also function recovery. So Dr. Johan is our physical rehabilitations consultants in the hospital. So the three of them are working together alongside with the nurses. We have also GP, we also have the nutritionist, and also the physiotherapy team as well. So this is the phase one. The phase one is always about the preoperative, and also what happened during the preoperative is the patient education, of course, and then medical optimizations, which is we have to check whether the patient had anemia, what is the nutrition level or the nutritional situations, and also whether the patient had diabetes. And also there are some pre-rehabilitation protocols that the patient needs to go through before they go to the surgery. And then as always, there's always a smoking and alcohol cessations. And for intraoperative, there's a standardized surgical workflow. There's a spinal anesthesia. There's a preference for spinal anesthesia, but there is a multimodal analgesia procedure, which I'm going to explain later. There's a TXA for blood conservations, and also there's a local infiltration analgesia and peripheral nerve block, or PNB, as part of the additional process for the spinal anesthesia. So this is the patient and family education before surgery. So the patient will go alongside with our GP. They will sign the informed consent. They will be educated for what will happen to their body, what is the procedure, what needs to be prepared. And then also there's pre-admission smoking and alcohol cessations. As we know that smoking cessations, it has to be at least 4 weeks before surgery. If it's not possible, quitting at least 48 hours before surgery still offer benefits. And also, and this it also includes vaping as well, or e-cigarettes. And then alcohol cessations, there are for social drinkers is 48 hours prior to procedures. For daily drinkers is below than 3 glass per day. And for heavily drinkers, it has to be stopped 4 weeks before procedure. So we have a definition of where and when we should stop the smoking and also the alcohol consumptions prior to the surgery. So why? Because there's a clinical rationale for this. The alcohol impairs platelet functions and also anesthetic drug metabolism and wound healing. So a tiered cessation protocol matched to consumption severity ensures optimal surgery readiness. And the patient needs to be very honest with us during this education process, because I believe this is what going to support them for the post-surgery procedure or protocols. And this is the check for the anticoagulant and also antiplatelet cessations, whether the patients consumes any aspirin or clopidogrel or any other anticoagulants. So we will make sure that all of these were stopped prior to surgery. And then pre-operative, we also give them a prophylactic antibiotics, which is there are exact times for prophylactic antibiotic administrations, and it's also recorded in the operating theater. And with this antibiotic prophylaxis, there's at discharge, there are no additional oral antibiotic prescribed. And this is I think this is supportive to the antimicrobial stewardship principle. And this is one of the benefit that we got from this ERAS protocol. So prophylactic antibiotics are timed, documented, and limited, and this protecting against infection without contributing to any antimicrobial resistance. So for rehabilitation timelines, there are some preoperative stretch and mobilities activities. There are also strength training as well, and there's a functional drills as well. So before the patients go to the surgery, the patient already undergoes some of the physiotherapy protocols which needs to be ensured, and the nursing team has to be immediately notified the rehabilitation team upon patient's arrival, uh, just before they got admitted to the hospital until they arrive at the post operation ward to ensure timely installation of the IPC for DVT prophylaxis as well. So there are a lot of things. It's not only the the stretch and mobility and also strength and functional, but also we have to prevent some of the DVT prophylaxis activities. So for intraoperative, this protocol required a tourniquet-free surgery. Why? The tourniquet-free approach eliminates the ischemia or reperfusion damage. And usually when we have this tourniquet, the patient it's really make the patients we cannot get the patients to have the 4 hours training post-surgery immediately because this protocol requires that the patient has to start a rehabilitation process like 4 hours after the surgery. So by using the tourniquets, it really inhibited them to have this 4 hours training after the surgery. And for intraoperative, also blood conservation and hemostasis. As I mentioned, there's a TXA perioperative IV dosing by body weight. And also there's an intraoperative topical applications. It's a weight-based IV dosing combined by topical applications. And it's applied directly to surgical field during the procedure. And the evidence or the impact is significant because it's reducing the blood loss and none of the ARAS patients required transfusion. So all of the things was carefully thought, and this protocol is, I think, is make every activities or the whole activity, the surgery activities is very seamless, and it's really helping patients to gain their to be independent soon after surgery. And also intraoperative, there will be no drain at all. So no surgical, no tourniquet, no drain, no catheter. So there's a specific wound closure strategies that they are using. And also the operation has to be date and time. The operation could not be exceeded 90 minutes. So thank God, because all of our surgery is around 70 minutes. We can watch the video later on. So you will have a better understanding. And then that will be Prof. Nicora's part as a orthopedic surgeon, and what will be the anesthesiologist's role in ARAS. So this is part of the Dr. Agus presentations where I'm going to share with all of you. So this is what he did for preoperative medical requirement. This is non-negotiable standards. So we have specific metabolic targets for HbA1c and albumin, transferrin, and others. We also have a cardiac assessment. This is mandatory for all patients. And we do a complete preoperative panel laboratory check, which consists of so many things. I think this is standards in every surgery in hospitals. And this is what's the difference from the ERAS protocol and with the other protocol. So we do have fasting, but it's not a total fasting. So we call it the 6-4-2 fasting protocol. So 6 hours before surgery, the patient needs to stop heavy meals or solid meals. But 4 hours pre-surgery, the patient could, they could still have juice, which is no fiber. They could still have light, clear fluids permitted. And 2 hours pre-surgery, they have this carbohydrate loading. So carbo loading, and they also consume sweet drinks. So what is the rationale? So carbo loading reduces post-op insulin resistance, decrease protein catabolism, and improve comfort entering the OR. So this is why this protocol is really reducing the patient's stress, because the patient is very happy prior to the procedure. They consume sweet drinks, they have the carbo loading, so they are happy when they are being brought to the OT. So and also we have this post-operative nausea and vomiting support. So this is also have rationals. So usually we have we give the preoperative and nausea, medication if the patient has any any um, anything, or probably they have something with that. But for this, actually, we give it prior to the surgery, so it's part of the pre-medication. So it will make sure that they will feel okay prior and during and also post-surgery. And this is the perioperative fluid guidance. So we have a very specific IVC formula measurement. Using the CI measurement, we use also ultrasound measurements. So we really have to measure what is the goal-directed fluid therapy prior and also during the surgery. And this is the anesthesia and pain control, the Duranto operative. As I mentioned, we don't really rely on spinal analgesia, but we also anesthesia, sorry, but we also rely on local rotation analgesia and also peripheral nerve block. So this is our journey for total knee replacement. So actually, from 2024 until today, we have shift from the regional anesthesia to the last, panel, which is combined of so many techniques. But for the last patients, we could be proud because the last patients we're not using any morphine, and we are not using any fentanyl. So 70% of success rate opioid-free recovery, which is, I think this is super important because opioid is one of the agents which cause nausea and vomiting in many surgery patients. Temperature control needs to be measured as well. We use the infusion warmer and also warmer blankets and also blowers. I think this is very common in peri-surgery. And for post-operative, the target will be immediate early mobilizations, which is from the day of the surgery. So you can see it's POD 0 and 1. So it's not the next day, but it's 4 hours after surgery. Why we could do that? Because we really keep the post-operative pain protocol to keep the FAST score very low. So VAS is 0 to 2 and VAS during rehab is 0 to 3. This is the things that we have done. So post-operative, the patient could eat as early as possible. So this is also not an option. This is a measurable quality indicators in our ARAS pathway as well. So as soon as the patient could reach the BROMAT score 0 to 1, so the patient could immediately get the early nutrition snacks. No urinary catheter, I think I already mentioned that. So reduce invasions and also promote independence soon after surgery. And for the early mobilization, this was done by Dr. Johan. So he's the one completing the ARAS principle. As we could see, there are 4 hours training, 6-hour trainings, and 12-hour trainings. There are DVT preventions synergy as well. And this is proven clinical impact, which really reducing our length of stay. So this is 4, 6, 12 hours. You could see that they have specific training for each of the hours. So the patient we have to measure the walking distance every day to assess patient's readiness for discharge. This is post-op the next day progressions. And actually what the milestone or accelerated milestone will be the 4 hours, 6 hour, and 12 hours. And we could really discharge the patients using this criteria that we call DREAMS. Drink well, remove IV line, eat well, analgesia target will be FAST score will be between 0 to 2. Mobilizations, they could walk more than 70 meters with walking 8, and they could sleep 6 to 8 hours a day. So this is the multi-collaborations pathway that we have. There are nursing team, nutrition teams, data and quality improvements, of course, orthopedic surgeon, anesthesiologist, physiotherapy, pain management, and internal medicine. So why the pillar must work together? Because this is the high value care that could really give us the best result possibles. So as I mentioned in the opening, that the critical caveat is with experienced clinical judgment, proper patient selections, and also sound surgical principles and technology and robotic assistance, we really have the core benefit and also achieve the ultimate goals of having this ERAS protocol in our hospital. So this is what we have. We cut the length of stays, 3 days. We could reduce 3 days from 5 days. Recovery time 50%. Complications is reduced by 60%. The pain is reduced by 50%. DVT 0%. Pneumonia 0%. Operating time 50%, 54% reductions, and early mobilizations 100%. Complete nutrition compliance 100%, and also readmission is 0%. These numbers are not aspirational targets, they are our actual targets, and this is what I love the most about this. What you've seen today is not 3 separate presentations, so it's one patient journey delivered by the team that walk it together every single day. So as a closing of my presentations, I will play a short video to all of you. I hope you could enjoy this. Oh, sorry. Just a moment. Okay, enjoy.
Prosedur operasi total knee replacement dengan robotic assisted di Rumah Sakit Mayapada Surabaya dengan menggunakan protokol ERAS. ERAS itu singkatan daripada Enhanced Recovery After Surgery. Artinya itu membuat pemulihan pasien secara lebih cepat dan tanpa suatu rasa nyeri. Jadi dalam hal ini di Mayapada sudah ada tim ERAS sendiri terutama untuk TKR robotik ini.
Untuk persiapan sebelum operasi, pasien pasti akan menjalani beberapa pemeriksaan terlebih dahulu untuk memastikan tubuhnya dalam kondisi yang fit. Maka akan ada serangkaian pemeriksaan mulai dari laboratorium sampai pemeriksaan fisik yang harus dijalani terlebih dahulu oleh pasien.
ERAS ini yang paling membedakan adalah soal karbohidrat loadingnya ya. Nantinya pasien ketika dirawat di sini, dietnya itu kita akan berikan tinggi kalori, tinggi protein. Isi di dalamnya itu pastinya nanti karbohidrat yang lebih besar daripada pasien-pasien berdiet lainnya. Kemudian protein bisa sampai 2 porsi. Ekstraknya itu ekstrak albumin dalam bentuk entah itu telur, entah itu ekstrak dari ikan gabus, atau ekstrak dari tulang-tulang sapi maupun tulang ayam.
Teknik anestesi yang direkomendasikan dan sesuai dengan protap ERAS adalah penggunaan regional anestesi. Kemudian untuk menjamin bahwa nyeri pasca operasi tidak terjadi, kita menambahkan dengan namanya regional block. Kita lakukan one shot di tempat tertentu, kemudian kita maintain sampai 24 jam atau 36 jam sampai dengan pasien pulang. Jadi dalam hal ini pasien langsung bisa menggerakkan kaki dan segala macam, kita sudah bisa melatih dia berdiri dalam 4 jam. Itu yang menjadi keunggulan penanganan nyerinya, kita sebut dengan multimodal analgesia.
Assisted robotik ya. Jadi ini TKR dengan assisted robotik, di mana operasi kita ini sesuai dengan ERAS internasional bahwa tidak boleh lebih dari 90 menit. Oleh itu mohon kerjasamanya. Jadi kita nanti tidak pakai tourniquet, tidak pakai drain, ya, dan tidak pakai kateter. Ini tentunya begitu supaya pasien cepat mobilisasi. Sebelum operasi mulai, mari kita bersama-sama berdoa. Semoga diberikan kemudahan dan kelancaran. Berapa menit itu?
3 menit, Bro.
Oke, alhamdulillah. Dan benar semuanya dibuat efektif. Rata-rata waktu tempuh kita rata-rata sekitar 70 menit lebih. Kalau ibu mau dipulangkan tuh ternyata ibu sudah memenuhi kriteria itu. Yes, itu semua adalah kriteria bahwa ibu boleh pulang. Meskipun ini hari pertama operasi. Jelas ya? Baik, hari ini ibu boleh pulang.
Okay, thank you so much.
Thank you very much, Dr. Dini, for your presentations. To those who may have just joined us, if you have any questions, feel free to send them in via the Q&A tab at the bottom. All right, I'll now like to introduce our third speaker, Dr. Jason Letran, Director of Clinical Operations and RoboCare Surgical Center, Chinese General Hospital and Medical Center, Philippines. Dr. Jason, please.
So, a pleasant good afternoon to everyone. So today I'll be discussing a little bit about robotic surgery, not about the clinical practice per se or the technique of the surgery, but more about acquisition, beyond acquisition, and how to build a sustainable robotic surgery program in an emerging economy or an economically challenged situation. And as a sort of disclaimer, I do not have any financial nor commercial conflicts of interest. And today I'll be discussing, although I am a urologic oncologist and robotic surgeon, but I'll be speaking in the capacity of clinical operations and RoboCare Surgery Center of Chinese General Hospital and Medical Center. The Chinese General Hospital and Medical Center is actually a premier non-stock, non-profit tertiary healthcare institution in Manila, founded 135 years ago. It is one of the oldest and most trusted hospitals in the Philippines, offering advanced patient-centered care with state-of-the-art facilities. And our tagline is providing exceptional care within reach. So nowadays, if you listen to the first two speakers, the emphasis is always on acquiring the robotic surgery in improving the patient care, improving surgical outcomes, minimizing invasiveness, and improving the quality of life of the patient. And most of the time, the conversation would revolve around, do we need a robot? Should we buy a robot? But in reality, the easiest part of a robotic surgery program is the buying of the robot. Buying the robot is the easy part because what makes a program sustainable is not just about plain and simple buying the robot, but it's about integration of the several factors that would contribute to the success story of a robotic surgery program. So after all, a robot sitting idly in the operating room is the most expensive piece of decorative equipment in the hospital. So the mindset should be shifted from that of an acquisition mindset to that of the sustainability ecosystem mindset. For the acquisition mindset, the goal is just to buy the machine. We focus on the financing, vendor selection, and maintenance costs. The hospital owns this particular machine run by a champion of the equipment. But when we talk about sustainability, we just don't look at the machine, but we are looking at building a program that will survive, grow, and create values year after year. We look into not only the vendor, but we look at the surgeon capability, the operational efficiency, and continuous advocacy. And the robot should not belong to just one particular champion, but it should be owned by the entire institutions so that the definition of recovery of investment is not just financial, but it's about achieving strategic relevance, the reputation of the hospital, the talent acquisition of better surgeons to be able to deliver better care, and market positioning as a premier robotic program of a country. So before we go a little bit deeper, maybe we have to understand a little bit about the Philippine healthcare landscapes. The healthcare structure in our country is that of a mixed public-private system, wherein advanced technologies are introduced primarily in private hospitals. And the healthcare financing, on the other hand, the PhilHealth or the National Health Insurance System provides a very limited coverage of insurance. Thus, there is a very high out-of-pocket spending, and the implications for robotics is that the high cost of the equipment plus the minimal reimbursement would pose us a serious question about the affordability of the usual patients to avail of the robotic surgery. Then because of that, will there be enough case volume to justify the investment? And will the surgeons adapt to this new technology? After all, if you look at the healthcare expenditure per capita, the Philippines' healthcare expenditure is about only a quarter of the average ASEAN average of $950 healthcare expenditure per capita, and the out-of-pocket expenditure as a percentage of health spending is 47%, which ranks number 3 among the ASEAN countries. So this would put advanced robotics as not just a surgical innovation, but it is indeed an immense economic challenge. So over the next few minutes, I shall share with you the journey that we took in Chinese General Hospital, where it all started. And the dream, like everything else, it starts with a dream. During the mid-2000s, while attending international conferences, I remember being mesmerized by the precision of robotic surgery. I can see how accurate the surgery was, how precise it was, and deep inside, I said to myself, one day, this will come to our country, the Philippines. Of course, back then, it sounded unrealistic. And however, I was always driven by the vision that our patients deserve the same quality of care as anyone else. So as I've said, every program begins not with the technology, but with the belief that it would be possible. And indeed, if you look at the robotic surgery milestone in Chinese General Hospital, it's indeed a 15-year journey. In fact, for the entire country, we were the first hospital to engage in an official meeting with the distributor of the Vinci robot in year 2007. And it took us 15 long years before we were able to perform our very first robotic surgery in September of 2022. Actually, I did the first robotic surgery in the country, but that was way back in 2010, ironically in another hospital. And then I moved on to another hospital, and it was only after 15 years after doing the first surgery that Chinese General Hospital got their first robot. And since then, there is no turning back. We were able to upgrade to the Da Vinci Xi in year 2024. And just last week, we were able to do our single port robotic systems, robotic surgeries, just last Saturday. So as you can see, our journey from growth to sustainability, our journey built the foundation of robotic surgery. And over the next few slides, I shall be discussing with you and explore with you what would be the pillars for us to be able to sustain a robotic surgery program. And the 5 pillars of sustainability would include, first and foremost, the volume. So that means that we need to have the proper number of patients for us to be able to make this particular investment a profitable or a possible one. Then the pricing. Certainly, the price of the robot should be placed in an affordable or value for money range such that there be enough patients that would adapt to this particular procedure. Then, of course, the training, because what's the use of a robot if there is no surgeon who will utilize this particular robot for the performance of surgeries to give better care for the patients. And of course, once we got the robot, we need to be able to look at the processes, the excellence across patient's journey, the process of not only surgical procedure, but it involves the entire team, the scheduling system, the reimbursement system, the admissions process, the evaluation, the results, and things like that. And lastly, course, the most important thing would be to be able to evaluate what have gone through in the process of robotic surgery, and that is the data gathering. Because after all, we have to defend the acquisition of robot with quantifiable metrics. So let's go to the first pillar, which is volume. The volume would actually protect the sustainability. As I've said, the biggest threat to robotic surgery is underutilization. While like any other institution, usually it's the urologic surgery specialty, which actually would be the flagship adapter. However, a single specialty cannot sustain the platform. So you can see that although initially there would be a high volume of urological cases with very sparse volumes of other specialties, we hope that we would eventually inspire and transform the other specialties such as general surgery, gynecology, colorectal, hepatobiliary, ENT, and thoracic surgeries to have an equal share or almost equal utility of the surgical robot. And after all, higher use, greater value, more lasting sustainability. And when we talk about sustainability, we want to expand the utilization across several specialties. And again, it's very important to emphasize that a robot sitting idly is the most expensive decoration in the hospital. Second is the pricing. Certainly from the hospital's standpoint, they would like to charge very high with a high margin, hopefully to recover or to recuperate the investment. But if you look at the particular model, if you look at the high pricing margin, there would usually be limited to only flagship cases, such as surgeons would hesitate to offer to the patient, and patients cannot afford this particular procedure, leading to low volume, idle robot, and loss of investment. Whereas if you lower down the margin, it would make the procedure more financially accessible, that would encourage utilization across several specialties, leading to high OR utilization and leading to sustainability and a small return of investment. And after all, we also look at the investment, at the ROI, not only from ROI of the surgical robot per se, but also the ROI from what we can gather from utilization of other concomitant hospital services, lots of ancillary services, imaging, and the likes. Third, and very important thing is the surgeons. We should build the surgeon not only to recruit, because buying a robot without investing in surgeons is like buying an airplane without trained pilot. And very important, it's the first few cases because it's the most important to lead to a sustainable growth. Because if there's a stagnation of cases, then it would lead to loss of trust and confidence in the machine, leading to further decrease in the utilization. So we have an onboarding process, starting off with an observation, then we do the simulation using dry lab and console practices, then they will be elevated to bedside assistants, and then eventually they will do the surgery with under the proctorship of more expert surgeons, and then eventually they would become mentors themselves because the trainees will become teachers in the long run. So my dream in forming a robotic surgery program is not just a service, but a living, evolving program, one that would mentor, train, and transform robotic surgery. And the entry of CGH in September 2022 gave me the chance to create and lead a program that reflects my vision, not just where we are today, but what the future could be. So from the very first milestone of a dedicated first robotic surgery team consists of urologists, we were able to form a dedicated urologic robotic team made out of a lot of specialists, even the nurses and the technicians, in order to provide a quality and dedicated robotic surgery program to the robotic urology team. And then later on, we were able to pass it forward to form a dedicated robotic surgery team of doctors of different specialties, dedicated nurses and technicians. And that is the birth of the RoboCare Surgery Center, where technology meets the human touch. So fourth is the processes. The fourth pillar is the processes. So we look into OR turnover optimization, dedicated trained nurses for robotic surgery, the ERAS program, inventory discipline, because we have to be able to keep track of the utilization of the consumables so that there will be no delay or no stagnation of cases. The anesthesiologists should be trained because of the inherent intricacies of robotic surgery, and of course, the scheduling system. And with regards to our surgical workflow, we also have very strict criteria, starting off with patient selection, scheduling, and then even the setup and the docking can be such a difficult procedure. Then the surgery itself, surgical turnover, and then data review, looking at the outcomes of our procedures. And this leads to the fifth pillar, which is a review of the data. From the clinical standpoint, we look into the complication rates, conversion rates, length of stay and readmission. Operational, we look into the case volume, specialty distribution, what specialties are lagging behind, what specialties are overcrowding, utilization time of the OR, and turnover times. Because after all, we should be able to do 2 or 3 cases in one single day if there will be a very efficient turnover time. And financial, we review the margins. We make a good balance between private and charity cases, look into the surgeon productivity as well. So what we measure here is the volume, the access, the quality, the efficiency, and the financial aspects. And all of these are good data that would turn debate into a disciplined improvement of robotic surgery program. And needless to say, marketing is very important as well. In building a strong brand, we are growing trust, we are expanding impact, and we have some strategies in order to market or to promote this particular program to the patients of our country. We look into marketing, visibility, and brand positioning. We look into physicians' referral networks. We look into public awareness and patient education, institutional branding and media presence, and corporate partnerships and sustainability. And this is the outcome, the results of 4 years or 5 years of robotic surgery in our country, in Chinese General Hospital. We started off last quarter of 2022. We have 32 cases, and the next year we have 133, and the next year 172 and 203 cases. And for this year, we are on track to beat last year's record because for the first 3 years, we have already 52 cases. And this is the journey of the entire Philippine robotic surgery program. You can see that the first 10 years is rather very slow. And then after 2022, there's a very steep exponential rise in the cases. And if you look into the 2022, it actually coincides with the entry of Chinese General Hospital. And this actually leads to a national movement because this the success story of Chinese General Hospital showed that robotic surgery can be performed in a relatively lower income hospital that caters to lower income group, such that more and more institutions purchase a surgical robot and more surgeons utilizes the robot and more patients take note and take advantage of the robot. And the next frontier, as the ecosystem matures, we now try to introduce alternative robotic platforms. And also we would like to go into something more advanced. And this is using the single port system. And just last April of 2025, we performed the first single port robotic surgery. And we were able to do 4 cases in the past 3 days. So by building the ecosystem before the machine, like what we did with 15 long years of planning and procrastination, hospitals move beyond just simple acquisition. but it would create a robotic surgery program that truly lasts. After all, sustainability is not about just buying the robot, but it is about building the institution that can sustain the surgical robot. So with this, I would like to thank you all for the very kind attention, and let's proceed to the Q&A portion.
All right, thanks very much, Dr. Jason. We'll now proceed to a very short Q&A session. May I invite Ms. Tran and Dr. Dini to turn on your cameras and mics? I think one of the key questions that came out is around balancing the investment into robotic surgical systems and also the pricing. So I think Dr. Jason briefly touched on that, the pricing strategy, how that affects margins and the long-term sustainability. Perhaps want to pose this question to the other two panelists as well. For Dr. Dini, Ms. Tran, what are your thoughts on managing that balance? Perhaps Ms. Tran first, briefly.
Yeah.
Ms. Tran.
So, well, as I
okay. Yes, Dr. Jason. Brief thoughts.
Okay. So as I have mentioned in my talk, the very important thing is not to put a very high price for the robotic surgery, because naturally from a hospital standpoint, the first thing that would enter their mind is to recuperate the huge investment. But we have shown that the higher the cost, the lesser people would avail of it, and then that would lead to stagnation. By lowering the price to a more or less affordable level, we would be able to offer this to more patients, and we would rely the return of investment not only through direct income from this particular machine, but we also would look into the income from peripherals, such as increase in the referrals for laboratories, for imaging, such as CT, MRI, and even PET scan. And then for those patients that would come to us for robotic surgery who eventually turned out to be not ideal candidates, that would be also a nidus or a point for them to go for other hospital-associated facilities, such as external beam radiation using linear accelerator or other procedures such as open surgeries for that matter. So in short, we should look into the ROI not only from a direct income from the use of the robot itself, but also from the entire system. More and more hospital services being tapped, more potential surgeons being recruited because they can see that this is a reasonable and reasonable endeavor, so that the robot will not stagnate.
Right. Thank you. Dr. Dini, your thoughts?
So actually, what I could share, the price for the robotic TKR procedure in Mayapada is the same with the manual one. So we don't give them any
Premium.
any premium cost for that for sure. And I think I agree with Dr. Jason. What we need to do is to give more access to patients, and we need to look at the cross-selling point as well from the ancillaries and everything, because I think we have to live in the heart of the patient. So if we really look for a very like the very fast ROI or very high ROI, those kind of things are we need to really balance on that.
Right, thank you. And Ms. Tran, lastly, your
yes,
thoughts
I
on
like
this?
just to add a few points. I totally agree with Dr. Jason and Dr. Dini. But for us, first we have, as a brand new adoption, we have to look at economy of scale, right? We have to try to aim at the program as how much number we would reach for capacity, utilization, all that. And of course, for the cost of our surgeon, we do not, when we talk to a surgeon, we all agree that the cost of surgeon fee for robotic surgery will not too much higher than laparoscopy, because actually it's a training curve for the doctors, and the doctors love it. And also my feedback from the doctors, for them, the effort is even less than laparoscopy to do robotic surgeries. And they would love to lower their surgeon fee to engage patients into the new program for the good outcomes. And in Vietnam, our hospital open, claims for all social insurance cases. We also have strong private insurance guarantee wheeling cases. So, we do our best in operational to support our patients to lower their bill.
Right, thank you. I think the last question I would pose is around how do you sort of get your surgeons engaged in adoption of robotic surgery? So were there pushback that you encountered when you tried to implement the technology, and how do you address that successfully? Maybe we will go back to Ms. Tran first, and then to the other two panelists. I think you mentioned the surgeons loved it at FB.
Yeah, for us, it's
Yeah,
not that
okay.
difficult of the question, more about select which doctors. And yeah, so I'm not
Okay,
a
no
doctor
pushback.
also. Yeah, so
Okay,
we have no problem to engage the doctor into robotic surgeries.
right. Over at Mayapada, was that the same story as well?
Yeah, I think there's no problem in engaging all of them wants to, they even
Okay.
want their own different type of robots. So like
So it's more of competition. I want to be first.
yeah. It's more like that.
Okay, and for Dr. Jason, did you, you really started off the robotic surgery journey way back. Did you find that the reception from surgeons towards robotic surgery has changed a lot over the years?
Yes, certainly. In year 2027, no one talks about a robot. In 2010, we were only two guys who did the robotic surgery, and it took a while for the cases. And if you can see the rundown of cases from year 2010 to the present day, the first few years has always been a very, very low level. And then eventually, as the results came out better, as more and more surgeons get the hang of it, then suddenly there's an exponential rise, such that everyone nowadays talks about robot. In 2024 alone, until today, we were able to get 12 additional robots. But from 2010 to 2024, there were only 4 hospitals that have the robot, and but since 2024 up, now we have additional 12 hospitals.
So it does look
And
like robotic surgery is growing really exponentially across the region. Um, yeah, we have to. Yeah, yes, Dr. Dini, do you want to add something?
Yes, and I think in Mayapada, what we learned, because we start small from the Valis one, and we want to acquire Da Vinci by the end of this year. So it's kind of give a very good overview of how to deal with robots and how to really have a trained surgeon to do that, and to have a very close look on the preparations, like the funnel for the patients, where can we get patients and everything. So I think it's good to have a good preparations before we start to talk about buying another robots. So
Yeah, yeah, I think that comes back to our really what started this webinar was the thought that the understanding that robotic surgery doesn't end at buying the system. That's actually the easiest part, right? As what Dr. Jason said. And there's a lot of work that needs to go into the preparation and implementation and sustaining it long term. So a very big thank you to our speakers today for taking time to take questions and also share your insights into your respective robotic surgery program. Unfortunately, due to time constraints, we have to come to the end of the Q&A segment. Also, a big thank you to the audience for joining us today. We hope it has been a valuable session for you. We do have more HMA webinars coming up, as well as our annual HMA conference happening 2nd and 3rd September this year in Bangkok. We hope to see you there. Yes, thank you once again to our speakers. We hope to see you soon and have a good day, everyone. I hope this has been a valuable session for you. Thank you.
Thank you.
thank you.
Thank you.
Bye bye.
Bye.